folks, welcome to the reading room. So in today's case, what I wanted to go over is a patient with a foreign body obstruction. So there's one thing that you think you're going to come to notice over the course of all these reading room cases, that we can never have enough cases of obstruction and we can never have enough cases of heart failure. Those are things that I think are super important to really just hammer home and get into our heads as common things that we see in the clinic and that we need to be able to evaluate. So let's dig down and take a look at this patient here. So this is a young dog, a 3-year-old spaniel cross, which is presenting to us for vomiting, and radiographs of the abdomen were taken. So let's see what we see. First thing that I'm noticing when I look at these radiographs is that there are a number of large loops of intestine. We've got a loop sitting here, curving along the ventral abdomen. We've got these loops sitting more dorsally, and then in the VD projection, you've got one oriented medial-laterally, which connects to this large segment here, and then might connect over to this loop over here, which is pretty big. So one of the questions we have to ask ourselves is this small intestine or is this colon? Because if it's small intestine, it's pretty large. When we think about judging small intestinal obstruction, we think about taking the largest loop of small intestine, looking at the diameter, and then comparing it to the smallest segment. And in those instances, if the largest segment is twice the size as the smallest segment, then it's probably obstructed, or at least twice the size. So that's one thing to look at. That's two populations of small intestine, or a differential bowel population. The other thing to look at is the character of the material in the small intestinal segments or in the intestinal segments and where they're located. So how can we determine if this is small intestine? Well, the first thing is the way it courses. If our colon is coursing through the abdomen, we expect it to sit dorsally, and then it would loop around here, and then we might get the cecum as a bit of a kind of comma-shaped gas bubble there. Similarly, in the VD projection, the expected course would be up, over to here. In this instance, obviously, the stomach is distended, comes all the way back to here in the ventrodorsal projection. So this could be colon sitting here and then looping around to there, but that doesn't explain well the differential bowel population. And it doesn't explain the material that's sitting in this loop of intestine. So the stuff that's sitting in this segment right here, to me, really looks like a cloth foreign body. So that's what this is. This is an example of a sock foreign body that's in the proximal jejunum or distal duodenum of a dog. So these are the distended segments of small intestine. And then the remainder of these smaller segments through this region of the abdomen, those are the empty normal segments post-obstruction. So those are aboral to the obstructed segment. If we weren't sure, there are a couple different diagnostic tests that we could do to really highlight it. The first and easiest would be a pneumocolon. So that's where we use a red rubber catheter to put air in the colon, and that will highlight the course of the colon and determine whether or not the foreign body is actually in the colon or the small intestine. And the other, of course, would be an abdominal ultrasound. We could give an upper GI contrast study, but in this instance, there's enough indication that tells me that, hey, this is obstructed. Let's get this dog to surgery and fix this problem. So this has been a sock foreign body in a dog, and we'll take a lot more looks at these over the coming months in the reading room, but I hope this has been helpful.